Hello, everyone. My name is Jeffrey Boertien. I'm a PhD candidate at the University Medical Center in Groningen, and I've been asked to provide input for the discussion on whether gut microbiome changes are important in Parkinson's disease. The answer to which I think is definitely yes, and I'm happy to explain a bit what the fuss is all about. And that there is a fuss concerning gut microbiota is quite clear when one tries to search for instance, microbiome or microbiota in PubMed. If you would have done this in 2010, this would have resulted in about 1,200 publications to be found. However, only 10 years later, last year, 2020, there were almost 21,000 publications. And this is also shown in the media. There are more and more headlines that link gut microbiome to all sorts of traits and behaviors, including various brain disorders, and of course, in our case, Parkinson's disease. And for Parkinson's disease, there have been over 15 studies now that all show dysbiosis in Parkinson's disease. And some of these findings are actually replicated quite robustly across various different studies. However, this is not the case for all these findings. And there are also there are several differences between gut microbiome studies in PD regarding their methodology, but also regarding the study population. And therefore, they also leave quite some room for confounding and even reverse causation. For instance, Parkinson's disease medication could be a confounder, since a lot of Parkinson's disease patients, also those included in these studies, actually use Parkinson's disease medication, but also the duration of the disease can be a confounder, since there is also a correlation between disease duration and the gut microbiome composition, therefore also hinting towards maybe the possibility of reverse causality for several of these associations. Well, if it comes down to the importance of gut microbiome for the disease, Parkinson's disease pathogenesis, one would ideally have disease-modifying randomized controlled trials. However, these are quite difficult to organize. On the one hand, this is because of Parkinson's disease itself. It's clinically quite heterogeneous disorder, and therefore one would require quite large sample sizes to actually assess a disease-modifying effect. As an example, I've given here numbers from a PPMI study that did the power calculation based on the gold standard of measuring clinical progression in PD, the MDS-UPDRS. And they suggest that you need 240 participants per group to find an effect of a drug or a medication that would slow disease progression by 37% after 1 year of differential treatment. And this is actually the most ideal group in which there has been no use of dopaminergic medication whatsoever throughout the course of the trial. And this is often not so easy to achieve in large numbers. But once participants would actually start using dopaminergic medication, this will actually increase the numbers of the required sample sizes quite a bit. On the other hand, this is quite difficult because the gut microbiome itself can also confound the potential disease-modifying effect that you want to measure, for instance, through increasing bowel motility. Because there have already been some trials with, for instance, probiotics. And what they found was that probiotics can actually increase bowel motility in Parkinson's disease, and therefore at least give a symptomatic relief of constipation, which might also improve the uptake of medication, and also an overall increase in well-being, because Parkinson's disease patients will have less constipation. And therefore, this symptomatic effect might actually be reflected in the outcome of your disease-modifying trial. But also there are some bacteria that have decarboxylases, which decarboxylate levodopa, and thereby reducing the bioavailability of the levodopa in the brain, and therefore also providing some sort of symptomatic or effects related to the levodopa uptake. So in itself, these findings are actually quite promising, and they suggest that probiotics and therefore gut microbes are definitely relevant in Parkinson's disease. However, if the motion concerns a contribution to the pathogenesis of Parkinson's disease, then these factors are actually confounding the results. So to really make a case for gut microbiota involvement in PD, we cannot rely on the gold standard of a randomized controlled trial. So we have to look for proxies that indicate gut microbiota involvement. And in my presentation, I would like to make the case for a gastrointestinal origin of PD through preclinical, clinical, and epidemiological evidence. But also I want to look into preclinical mechanistic studies involving the direct vagal pathway of gut-brain communication, but also the indirect circulatory pathway of gut-brain communication, showing that there are interactions along this axis that are relevant for Parkinson's disease pathology. So when we say that there is a case for a gastrointestinal origin of PD, it means that the PD pathology at its core might actually start in the gut. And this PD pathology concerns the aggregation of alpha-synuclein. And the idea is that if alpha-synuclein misfolds, it actually forces other still normally folded or natively folded alpha-synuclein in this misfolded conformation, and thereby clumps together and starts to aggregate. And this can then, of course, starts to spread because it will find new alpha-synuclein to also be aggregated, and therefore it spreads in what is called a prion-like manner. And the idea is that this prion-like spreading might actually begin in the gut and then slowly work its way upwards along the vagal nerve to the brain. And there are three lines of evidence to support this. First of all, there's preclinical evidence because this line of spreading has been replicated through, for instance, through rotenone mouse models in which gastric rotenone or intestinal rotenone, a pesticide, leads to alpha-synuclein aggregation in that area, and then the spreading was replicated, or through the injection of alpha-synuclein fibrils or aggregates in the intestine or in the stomach, and then also this spreading was replicated. There's also clinical evidence. Most well known is, of course, constipation, which is an early non-motor symptom and can occur up to 20 years before diagnosis. So it might be the earliest manifestation of PD. And there's also a quite recent imaging study in which PET images at certain points along the gut-brain axis have been investigated, and what they showed was sequential denervation starting along the gut-brain axis from the periphery towards the brain, or actually vice versa. And that or is quite important because it shows that this might not be important for all Parkinson's disease patients, but there might be subtypes for which this is important, a so-called body-first subtype versus a brain-first subtype. And lastly, there is epidemiological evidence for this association as well. For instance, people who have received a phlebotomy in the 70s till about the 90s for dyspepsia, they have a lowered risk of developing Parkinson's disease. But there's also the association between gut inflammation and then in particular inflammatory bowel disease and the later risk in life to develop Parkinson's disease. So then from the idea that Parkinson's disease, at least in a subset, can start in the gut, then the question is, of course, to what extent can gut microbiome and the changes that we've already found in the gut microbiome of Parkinson's disease patients, to what extent can they contribute to the disease? And therefore, I would like to start with the first direct pathway of vagal transport of alpha-synuclein, because as mentioned, the idea is that this alpha-synuclein aggregation and then the prion-like propagation might start in the gut, However, it is not necessarily the case that it is alpha-synuclein that is initially misfolded and leads to these aggregates. It could also be another protein with the propensity to misfold, a so-called amyloid, that could be the jump starter of this whole cascade of events by also forcing alpha-synuclein to have this misfolded conformation and then starting this aggregation and prion-like propagation. And amyloids are not unique to humans, and also bacteria can produce amyloids. And one of them is curly, which is produced by E. coli, which is a bacterial amyloid, one can say. And what has been shown in, for instance, worm models of C. elegans, but also in 2 different rodent models, one including an alpha-synuclein overexpression model, is that when these models were fed bacteria that included curly as an amyloid, that this would enhance alpha-synuclein aggregation. So they found evidence of cross-seeding of curly to alpha-synuclein, which then would jumpstart the aggregating cascade and the prion-like propagation. A second study I would like to highlight actually concerns not the direct pathway, but the indirect pathway of circulatory factors that can influence the communication between the gut and the brain. And this is the study by Sampson et al., which was conducted in 2016. And they used an alpha-synuclein overexpression model. And normally, if this mouse has a normal, let's say, mouse microbiome or gut microbiome, these alpha-synuclein overexpressing mice, they develop symptoms at about 12 weeks of age. However, you can also raise mice in a germ-free environment, in which case they do not have a gut microbiome. And quite interestingly, these mice then did not develop or at least less severe symptoms and less severe pathology. So the next step in this experiment was to then transplant the microbiome of healthy human participants in these germ-free mice. And what the investigators found was that the symptoms would then return. And if they would take it even one step further and would transplant the gut microbiome of PD subjects, the symptoms would return even earlier and more severely. So this indicates that there is something within the gut microbiome that is somehow contributing to the pathology in PD. So the authors wondered what this could be, and they thought this could maybe be due to the metabolites of the gut microbiome, since different microbes produce short-chain fatty acids, which are the product of bacterial fermentation of dietary fibers. And they knew from previous literature that these are important in potentiating microglia and thereby also potentiating the inflammatory response in the brain. So what they did was they took the germ-free mice again, and now they fed them with short-chain fatty acids. And what they would then see was that the symptoms would re-emerge again, and also the pathology would re-emerge again. However, this finding is somewhat controversial because in PD microbiome studies, it was actually found that short-chain fatty acids levels in the feces are actually lower in PD. So it is a question whether the findings can actually be translated from the mouse model to the human situation. And quite recently, there has been a replication study of this study in a so-called organ-on-a-chip model. In this case, this means that there were 2 compartments with human tissue, one with intestinal tissue and one with brain tissue. And these compartments are connected through a fluid chamber. So that you can study the communication between these different compartments. And what they found was a differential effect of short-chain fatty acids on PD versus non-PD cerebral tissue. And in this case, it was also the case that in PD affected cerebral tissue, that there was a deleterious effect of the short-chain fatty acids. So that would be a first indication that the findings of the previous paper in the mouse model might be translatable to the human situation, and that short-chain fatty acids might have a different effect in PD subjects compared to non-PD subjects. So in conclusion, what we have found is that gut dysbiosis has been robustly associated with PD status. There is preclinical, clinical, and epidemiological evidence that suggests that PD begins in the gut, at least in a subset of patients. And there are preclinical studies that indicate critical interactions between the gut microbiota and PD pathology. So based on this, in the absence of a randomized controlled clinical trial that shows disease modification or altered disease risk, if asked the question whether microbiome changes are important for PD pathogenesis, I would definitely say yes. However, I think additional research is still required to differentiate confounding effects from promising microbial candidates that can actually contribute or might contribute to the pathogenesis of PD. And therefore, I think we could better inform future clinical trial design if we would, for instance, perform gut microbiome studies in drug-naive de novo PD subjects. So we do not have the confounding effects of disease duration and or at least less confounding effects of disease duration and no confounding effects of the Parkinson's disease medication. Also, we can use Mendelian randomization as a genetic tool to distinguish what is more likely reverse causation or confounder from potentially putative causal effects. And quite recently, there has been a Mendelian randomization study on the gut microbiome that, for instance, shows that the association between Bifidobacterium and Parkinson's disease might actually be based on reverse causation. And lastly, we can also still benefit from multi-omics studies because next to the taxonomy that might be important, it is of course also quite important to actually have a look at the metabolic outcome and the metabolic interactions between the gut microbiome and the host. So all in all, I think that the gut microbiome is definitely important in PD, but the challenge still remains how to separate putative causal effects from epiphenomena.